Myself, Dr. Vrishali Kulte from Bayer Medical Team. On behalf of Bayer, I would like to welcome all of you. Thanks for taking time from your busy schedule and joining us for today's great scientific session. So thanks and welcome to all of you. With this, I would like to introduce our moderator, Dr. Ritesh. Dr. Ritesh is from LV Prasad and he is our head of the Liliac Image Reading Center. And please welcome Dr. Ritesh. He will introduce our panelist and our chairperson. So welcome to Dr. Ritesh. And I'm sure we are going to have a great brainstorming session. So welcome to you all.
Thanks a lot. Thanks a lot, Bayer, for arranging this amazing international speakers program for us. And I would start by welcoming our panelists for the session today. First up, we have Dr. Arvind Kumar Maurya, Additional Professor of Ophthalmology from AIIMS Bibinagar. Along with him, our next panelist is Dr. Sriram Simakurti from Shankaraya Hospital, Hyderabad, the Chief Medical Officer for the hospital, and Dr. Malika Goel ma'am from Apollo Hospital, Jubilee Hills. And last but not least, the chairman for the session today, I welcome Dr. Ajit Babu from the lead consultant at Yashoda Hospital, High Tech City, the chairperson for the session today. And I would request him to please introduce our international speaker for the day, Dr. Babu.
Yeah, I'm very much thankful to Bayer team for giving me this opportunity. And I take a lot of pride in introducing Professor Michael Stewart, who is a professor and chairman of ophthalmology at Mayo Clinic, Jacksonville, Florida, and Knights Templar Eye Foundation Professor Ophthalmology Research. He completed his medical education and Vitreoretina fellowship at different schools, and his primary research interests are chorioretinal vascular diseases and age-related macular degeneration, diabetic retinopathy, and complex vitreoretinal surgeries. Additionally, more importantly, Michael Stewart is mainly interested in ocular pharmacology, which is very rare combination between a vitreoretinal surgery and ocular pharmacology. And he is interested in analyzing the drug half-lives and dosing frequencies and long duration treatments for diseases like age-related macular degeneration. His capabilities are very, very essential for today's subject matter, that is age-related macular degeneration. And we invited Professor Michael Stewart for his talk. And more importantly, what I should say is probably he's the most frequent international speaker attending for Vitreoretina Society meetings. Thank you, Michael, for your association with us, both India as well as all the retinal surgeons here. Thank you.
Dr. Babu, thank you very much for the very kind introduction. Always a pleasure to be back in India and really enjoying this trip, 1 week through 6 different cities in India. Thank you to Bayer for putting this meeting together. Thank you everybody here in Hyderabad, as well as those of you who are joining remotely. So we appreciate your participation. So let me start this off and, oops, if you can have my talk, please. So my talk is going to be on several different topics, but we'll start by talking a lot about fluid, and we'll morph that into talking about switching. There we go. That was it, I think, or not. No, that's not it. There we go. And then we'll give some cases as well, and cases that I've used in terms of switching where I've been pleased and switching where I've been surprised, especially with our current medications. So we'll start about fluid compartments quickly, and many of you have heard me speak about this in the past as we talk about the fluid compartments of intraretinal fluid, subretinal fluid, and sub-RPE fluid as it pertains to age-related macular degeneration. And the top line data suggests that intraretinal fluid is virtually always adverse to visual outcomes. Patients with intraretinal fluid present with poor vision. They get poor visual acuity outcomes and they get poorer improvements in vision. Subretinal fluid seems to be nearly the opposite. And that is that patients may present with better than average vision at baseline. They then have better improvements and better final outcomes. And then finally, sub-RPE fluid. The sub-RPE fluid generally seems to be agnostic or neutral. It doesn't seem to adversely affect the vision unless it's associated with intra or subretinal fluid. So why? Why do the fluid compartments matter and why this association with vision? So in my opinion, it's not so much the fluid and what its local effects are as to how it affects the vision, but rather, I think fluid is a proxy for integrity of the outer retinal segments. And if you look at many of your OCTs in patients with subretinal fluid, with intraretinal fluid, you'll find a very high correlation with either integrity of the outer segments, which often is associated with subretinal fluid, or loss of the ILM, which is associated with intraretinal fluid. And so I think that's where this comes into play, is that it's not the fluid itself that's a problem, but it's the fluid itself that's a biomarker of how well the photoreceptor outer segments are doing. The RPE is a little different. And probably what happens in RPE is you get loss of integrins, which are the molecules that help hold the pigment epithelium down to Bruch's membrane. And those molecules are VEGF sensitive. So in a high VEGF environment, it's not unusual to think of integrin breakdown and RPE detachment. So how does that come into real life? Well, there have been some studies, mostly retrospective analyses. One prospective study, which was the fluid study out of Australia, that looked at tolerance of subretinal fluid. And what they did was they took patients with treatment-naive neovascular macular degeneration, and they were treating everybody with ranibizumab, and they randomized patients with subretinal fluid into two groups. The one group, they said, we want to try to get rid of the subretinal fluid, and we're going to treat aggressively to try to do that. The other group, they said, as long as the fluid is less than 200 microns, then we're going to tolerate it and not treat those patients. And so they then looked and said, well, what are the visual acuity outcomes over time? And what was the treatment burden? And so when you look at the outcomes over time, the dark brown is those that were intensively treated, and the more yellowish are those that were treated tolerating subretinal fluid. And you can see that whether you're talking about visual acuity improvements by letters, or whether you're talking about patients gaining 15 letters, the two groups behaved exactly the same. So the tolerance of fluid, which required fewer injections, did not seem to adversely affect the vision. A prospective analysis suggesting that fluid in the subretinal compartment can be tolerated. We do have some phase 4 prospective trials put on by Bayer that also suggest the same thing. The Aries trial on the upper right looked at tolerating subretinal fluid of less than 50 microns and extending them. Not only did they say, we're okay with that, we're actually going to use that as an extension criterion. Altair did not do that. If it was residual fluid, patients were maintained, and the only reason they could be extended is if they had no fluid whatsoever. So it was a little bit different. But when you look at the results of that, you found out that both studies actually did well tolerating fluid or extending in the presence of subretinal fluid. Probably the best data with regard to intra versus subretinal fluid comes from a post-hoc analysis of the Harbor trial done by Genentech, where they compared 0.5 milligrams to 2 milligrams, or the super dose of ranibizumab. And they did monthly treatments and they did PRN treatments, so 4 different treatment arms. And in their post-hoc analysis, they found that intraretinal fluid always was contraindicated with respect to visual outcomes. Poor visual acuity at baseline, poor change in visual acuity. Subretinal fluid you see on the right had patients who generally had better visual acuity at baseline and better improvements in visual acuity. And we have data, post-hoc analyses from other very large randomized trials. The VIEW trials broke down patients' visual changes by fluid presence. And you can see with the intraretinal fluid that the presence of fluid had a poorer visual outcome than the absence of fluid, whereas for subretinal fluid, it turned out to be exactly the same. Patients with persistent subretinal fluid did just as well as those patients without subretinal fluid. In their post-hoc analysis, they showed, when you look at the intraretinal fluid, that the absence of fluid did better, the presence of intraretinal fluid did worse. On the right-hand side, the presence of subretinal fluid did better, both in terms of baseline visual acuity results as well as improvements over time. The post-hoc analysis at 5 years of the CAT trial showed exactly the same thing. Fluid did not seem in the subretinal space to be contra to good visual outcomes. We talk about drying of the retina, and we can never really talk about that completely without talking about brolucizumab, which I think most of us agree is a very good drying agent. We have other problems with it that we have to manage, especially the inflammation part of it. But we do see that brolucizumab actually dries the retina better than aflibercept in the phase 3 trial. However, the visual acuity outcomes were exactly the same between the two molecules. So for some reason, that extra drying effect of brolucizumab did not correlate in any way to improve visual outcomes. And we'll go through that in a few minutes to see why. So we did a literature meta-analysis and a comprehensive search of the literature looking at studies that actually talked about the presence of fluid by compartment and how they correlated with visual acuity. And so when we looked at data with intraretinal fluid and 1-year visual outcomes, we found that every study that described those showed that intraretinal fluid is adversely affecting visual acuity. When we looked at subretinal fluid, it was pretty much the opposite. It broke down about 50-50 that the subretinal fluid did not seem to affect visual outcomes or actually was associated with better visual outcomes. And then when you look at 2 years, we found the same thing. Fewer trials were able to persist through 2 years, but the subretinal fluid, those that showed the data, it was adversely affecting vision, whereas for subretinal fluid, it was either in favor of better vision or it was neutral to visual acuity. And so again, more data to support this compartmentalization of it's not a matter of having fluid, it's a matter of where the fluid is that ultimately affects your vision and probably should affect your strategy. We go back to the Hawk and Harrier trials with brolucizumab. And if you look at the top left in green, you see that more eyes treated with aflibercept had subretinal fluid, but yet the visual acuity results were exactly the same. But yet those eyes that were treated with brolucizumab had exactly the same percentage of patients with persistent intraretinal fluid as aflibercept. So the fluid that mattered, the intraretinal fluid, brolucizumab was exactly as effective as aflibercept or vice versa. For the fluid that didn't seem to make that much of a difference, subretinal fluid, there was a difference where aflibercept eyes actually had persistent subretinal fluid in a higher percentage. Now, some people would say that's probably a positive. And the reason it could be a positive is that the subretinal fluid is a compensatory mechanism that actually nourishes the photoreceptors and the pigment epithelium and perhaps prevents macular atrophy down the road as opposed to complete drying. So look at subretinal fluid as persistent subretinal fluid is not necessarily your enemy, but rather your friend. Look at intraretinal fluid as something to try to get rid of at all costs. So what about the other drugs? What about faricimab? Well, originally Genentech introduced faricimab as a superiority drug. They wanted a result that was superior to standard therapy, and they used ranibizumab as standard therapy. But in their phase 2 Avenue trial, they quickly found that faricimab was not a superior drug in terms of visual acuity outcomes. And so after Avenue, they pivoted and they went for durability. And in Tenaya and Lucerne, they looked at a durability segment where they tried to extend patients receiving faricimab to show that it lasted longer, because they knew that when it came to visual acuity, and you can see by the top graphs, the visual acuity results at 1 year are essentially the same, whether treated with aflibercept 2 milligrams versus faricimab. And then there's been a lot of talk about faricimab being an excellent drying agent. And there certainly seems to be data out of Tenayo and Lucerne that after the first 3 injections, the macula tends to be a little drier with faricimab treated patients than with aflibercept treated patients. But what you don't hear is that that's very short-lived, because when you look at the bottom in green in both trials, you can see that once you reach about week 16 to 20, that you have this seesaw effect from both drugs and they overlap, which means that the drying effect from aflibercept after 20 weeks is exactly the same as the drying effect from faricimab. And so the drying effect is only advantageous for the first few injections. Once you reach week 20, the drying effect seems to be the same as you extend out through the end of the first year. So to summarize this, optimal management of patients really is in part a management of fluid. And we have to be nuanced because all fluid is not the same. We want to try to get rid of intraretinal fluid. We will tolerate subretinal fluid as long as it's been associated with stability and it's been associated with improved visual acuity. And so this is part of the strategy of individualizing therapy, which fits so well with our treat and extend strategy that we use. And so proactive, treat and extend, try to get rid of intraretinal fluid, be happy tolerating subretinal fluid. Don't worry about pigment epithelial detachments unless one of 2 things, unless it's very large, and the literature suggests anything over 390 microns thickness is a high risk of retinal tear, of RPE tear. And the other one is enlarging PEDs while on therapy. That's another one that worries me, and those are ones I will treat very aggressively. You might induce a tear, but if you don't do something, you're probably going to get a tear spontaneously. So RPE, we pay a little bit less attention to. So let me show you a couple of clinical cases from my practice, cases that you'll recognize in terms of response, but some of these I've been surprised at the response or lack of response to medications. This is the patient presented to me, former US Marine, 20/40 visual acuity, and you can see he's got sub-RPE fluid, subretinal fluid, intraretinal fluid. So he's got all the compartments. What am I going to want? I'd like to see subretinal fluid improved. I'd like to see intraretinal fluid gone over the course of the first 3 injections till we get to stability. He's got a type 1 choroidal neovascular membrane. So here's how he is after 3 monthly bevacizumab injections, because for a long time, we've treated a lot of patients with bevacizumab initially. You can see that his visual acuity is getting worse. And when you look at the RPE, it looks like the RPE detachment is actually getting thicker. So we can debate how long to wait before switching patients. And there's data to suggest that at least going through 6 months is very reasonable. But if patients are getting worse through the first 3 months, those are ones I'm going to switch therapy, because now I'm in a position where I may have an enlarging RPE detachment and tear. I'm going in the wrong direction. And so I switched him to aflibercept 2 milligrams. And interestingly, after the first 3 injections, he completely dried up all his fluid. Even his RPE detachment completely dried up. And he did very well. I extended him by 2-week intervals. I got him out to 16 weeks. And after a couple of years, I said, let's stop therapy and watch. This other eye was doing fine. So we did that. But then when I was away, he came back complaining of some paracentral scotomas in the treated eye. And you can see that there is some intraretinal fluid in the papillomacular bundle area, which probably is suggestive of outer retinal damage. And you look where the intraretinal fluid is, and you can see that though this green scale, the color scale is not the best for looking at retinal layers, particularly the ILM, you can see that you do have loss of the ILM in that area. Again, that correlation that I've said before. And so what happened was he saw one of my partners and he went ahead and treated with brolucizumab, and unfortunately the patient hemorrhaged. So now you've got a very large subretinal hemorrhage, you've got fluid, and over the course of 1 year, you end up with a disciform scar, and basically a loss of good central visual acuity that's irreversible. So this was a big disappointment. Now he comes back 6 months later complaining of vision in the left eye. And so not surprisingly, he's got a multilobular RPE detachment, again, consistent with type 1, and he's got subretinal fluid. So I start him on aflibercept every 4 to 6 weeks, and 9 months later, I get him at about 20/40. I never get rid of the fluid, but again, I'm tolerating the subretinal fluid and I'm not chasing the pigment epithelial detachment. And so he's actually done well, and I'm treating him about every 8 weeks, and he's still maintaining visual acuity in the 20/40 to 20/50 range with an appearance that looks like this. In this one-eyed patient, especially knowing the history of his other eye, I'm never going to stop therapy in this eye. So we talked about switching. And so when do we switch and what criteria do we use? And the short answer is there's nothing that's widely accepted, but there are certain criteria that seem to be most commonly used. And I think if we keep those in mind, then for applying this to our practice. Obviously, switching only comes into play when we have lots of therapy. If we go back, Dr. Babu, if we go back 20 years, what could we switch to? Nothing. We had one therapy and that was it, right? So it makes our life for our patients probably better. It makes our lives a little bit more intellectually challenging, but nevertheless, it's a much better place to be, to have multiple options compared to what we were. And really our reason for switching is a incomplete response or a lack of response. The question is, how do we define it? Well, people will look at primary response, which is 1 month after the last loading dose. They'll talk about secondary anytime after the 4th visit. And so we sort of couch our switching decisions based on primary and secondary responses. Here is one attempt to try to classify response from good, partial, poor, or no response based on both morphology, what's the OCT look like, and functional, how many letters of vision have we gotten? And so easy numbers to remember by this scheme. A good functional outcome is greater than 5 letters. A bad functional outcome is a 5-letter loss. And partial or poor is somewhere in between. Good morphology is a CRT of less than 75% of baseline values. And bad is unchanging CRT. So you can easily remember those in terms of good and bad response. Obviously, if you have a good response, you're going to continue along and probably apply your therapy of choice. Most of us as treat and extend, we've moved away from PRN, not because it doesn't work, but we know it works inferior to standard monthly therapy. Multiple episodes of recurrent disease. And every time we have recurrent disease, we have fibrosis and damage to the outer retina, hence vision loss. Response. And if it's no response, we're going to go ahead and switch therapies. The question is, when do we switch? And so we'll get into that. Oops. Come on. For some reason, there's no video. Oh, here we go. Okay. So as we talk about switching, is switching really work? In most patients, it doesn't work as well as we hope it will. I think there are, in my opinion, there are only 2 really good switching studies that have ever been done in medicine. By really good, I mean controlled, planned, prospective. I don't know what's going on with this micro. But we'll talk about the ones that are out there right now. Unfortunately, I'm sorry that all this has happened. So this was a study out of Japan, and it looked at eyes that were previously treated and then switched to faricimab. The results were actually disappointing. About 90% of patients actually discontinued faricimab treatment because aflibercept 2 milligrams. 73% of those switched back to aflibercept. That's a common theme to keep in mind, that when we switching is like playing poker when you're making high bets in poor situations. And there's a great variability here. And you should always be prepared to switch back if you make a switch, because you might get an adverse outcome and you may not get the result you're looking for. Another study out of Japan, again, looked at patients previously treated with aflibercept, but at intervals of less than 8 weeks. And when switched over to faricimab, still the majority were not out past 8 weeks. 70% of those were still at a 8-week or less interval. So switching from aflibercept to faricimab in the majority of patients didn't seem to make much of a difference. Here was a study that compared faricimab to aflibercept 2 milligrams. It actually did better. I don't know what's going on with this. And this study out of London with patients with diabetic macular edema looked at switching patients to faricimab after treatment with 2 milligram of aflibercept, and they found that the visual acuity changes were very minimal, less than 1 letter. And when they looked at the fluid or the treatment intervals, the majority of patients were still treated very frequently. So the switching in that case in these diabetic macular edema patients didn't seem to make a big difference when going from aflibercept 2 milligrams to faricimab. And this study out of, you'll recognize Dr. Siva Prasad, so this is out of Moorfields, where they looked at patients with diabetic macular edema treated with faricimab versus aflibercept, and they found comparable short-term anatomic and functional outcomes. So once again, there doesn't seem to be much difference between the two drugs, and switching more often than not doesn't make a significant change in terms of visual acuity outcomes or in terms of treatment intervals at the end case. I mentioned before 2 treatment studies that I think have shown switching works under the right circumstances. Neither is macular degeneration. One is DRCR-NET protocol AC, where they took patients with diabetic macular edema and then switched them from bevacizumab to aflibercept, and they found that switching according to certain criteria after 3 to 6 months did seem to make a difference in patients caught up in terms of their aflibercept control group. The secondly is SCORE2. SCORE2 was months with aflibercept versus bevacizumab, and after 6 months, patients with bevacizumab who didn't respond well were switched to aflibercept. And they found that on average, they improved almost 10 letters when they were switched to aflibercept. The people in aflibercept who were treated for 6 months and more marginal because they only improved by 2.5 letters. But both of those studies were prospective, randomized trials, switched according to preset criteria, and they showed that switching does work, but switching, you can use it. Unfortunately, neither shows us macular degeneration. Here's another switching study that actually surprised me. This patient, bilateral diabetic macular edema, this patient looked at baseline 20/50 in the right eye, 20/70 in the left eye. And so I started the net protocol T. And you can see that over the course of about almost 6 months, the patient did fairly well. Visual acuity goes from 20/50 to 20/30 in the right eye, 20/70 to 20/50 in the left eye. Neither eye is fluid free, but both eyes did reasonably well. And so she improved, but she said, is there something else we can do? And in the United States, we have a lot of advertisements on TV for these drugs. I don't know if you see that in India or not, but we get them all the time, the newer drugs, the second generation. And so the patient says to me, well, I've seen these ads on TV and people are getting 16 weeks. Can we do those drugs? I took a deep breath and said, sure, let's try that, because the drugs generally work well. Why not? So we're going to go ahead. And I said, let's do something a little bit innovative. Let's switch your right eye to brolucizumab. Let's switch your left eye to, and let's see what happens. And so here's what we did. Here's monthly injections, brolucizumab in the right eye, faricimab in the left eye. And what really surprised me was the patient went right back to where she started, which surprised me a lot. But remember the dictum before, if a patient is switched and gets worse, switch back. So I convinced her to switch back, and we did this. And now you can see she's going from here, and she gets down to about 20/30 once again, which is where she had been at her best. And 20/70, again, back to 20/50. Once again, neither eye is perfect, but both eyes are doing reasonably well. So this points to the idiosyncratic reactions people get to drugs. Some people respond much better to one drug compared to another for reasons we don't understand. When you think about this scientifically or mathematically, and you look at both visual acuity results as well as central retinal thickness, central subfield thicknesses on our graphs over time, always look for the standard deviation units or the confidence intervals, because you can see they frequently overlap. And that overlap suggests there's going to be a lot of variability among patients. And just because a patient doesn't respond to one drug doesn't mean that they're going to do better on another drug or vice versa. So interesting lesson learned, always switch back when needed. Another patient with diabetes, 81-year-old lady, followed by me for several years. I had done some modified grid laser in the past for her diabetic macular edema. Eventually switched her from bevacizumab to aflibercept, 2 milligrams, and she looked like she was doing okay. Some residual fluid, 20/25. Unfortunately, despite treating her every 4 to 6 weeks, look what happens to her over time. And she ends up 3.5 years later looking like this. She's 20/40, and I don't like the direction this is going. So now I've got faricimab available, so I switched the patient to faricimab. And you can see here's how she looks after her last aflibercept. Here's 1 dose, 2 doses, and 3 monthly doses of faricimab. Now she's 20/70, and she's gotten worse. So again, just because we switch, it's a high-risk poker game. We've got to always be ready to switch back. And that's what we're going to have to do in this patient because she's responded poorly. Does this exist in a vacuum? Well, I was at a meeting with Peter Kaiser, and the question came up as, well, what happens with your faricimab patients who are switched from aflibercept? And they looked at the Cleveland Clinic data, and what they found was about 1/3 of them got better, 1/3 of them stayed the same, and 1/3 of them got worse. And those patients that got worse, when they were switched back to aflibercept, they got better again. So once again, you can switch, be prepared to switch back. Otherwise, you might get to the point of losing a lot of patients. This is the Truckee study. Truckee was a phase 4 study done by Genentech with faricimab, and it looked at sort of early real-world data. Most of these patients were pre-treated. Most of those were the aflibercept. Some of them were treatment naive. The treatment naive patients did fairly well. The switching patients improved 1 to 2 letters, so they didn't do very well. But these are the studies where, as a journal editor, I really dislike real-world experience, switching studies, because switching studies, other than the 2 I mentioned, the DRCRnet, AC, and SCORE2, they're never controlled, and they're never with preset criteria that look really good. So these are the studies that, though give us some interesting data post-approval, are not data that I use to actually tell me how to manage my patients. This is a very interesting paper. This was in JAMA Ophthalmology, and I want you to read the title. Evaluating the effects of switching anti-vascular endothelial growth factor drugs for macular degeneration, diabetic macular edema. And what they didn't say in the title was in the DRCRnet protocol I and in the CAT trials. So those of you who know the study design know that there was never switching in those trials. They didn't switch. But what they did was they looked at patients at 3 and 6 months after initiating therapy who were incomplete responders, who would fit the criteria that most people would use to say, you're not responding well, I'm going to switch you. But then they followed these patients because they didn't switch them, they used the same drugs, and they found that whether they were treating with macular degeneration or diabetic macular edema, patients actually got better, 3 to 5 letters better, just by keep continuing to treat after 3 or 6 months of initial poor responsive therapy. So many of our patients who we switch, we've not given enough time to. And so that's why I tend not to switch too early unless the patient's getting worse, because it may not be that they're non-responders. It may be that they're late responders. So always keep that in mind whenever you're looking at switching patients, is have you given the eye sufficient time? Protocol T, many patients were getting continued improvement through 6 months with each subsequent injection. I don't know why it likes my video since I don't have one. All right. So can targeting other pathways be of value? Aflibercept, of course, is mostly VEGF and placental growth factor. But we're going to talk a little bit about Ang2 because it certainly got a lot of play with faricimab. What people don't generally know is that Regeneron looked at Ang2 actually before Genentech did. And they developed a molecule called nesvacumab. Nesvacumab was an antibody against Ang2. And what they did was they used it as combination therapy in patients with macular degeneration and diabetic macular edema. Nesvacumab and aflibercept compared to aflibercept monotherapy. And what they found was they really didn't make much difference, much predictable difference in terms of visual acuity results over the course of 36 weeks. So as a result, Regeneron went away from Ang2 because they couldn't demonstrate superiority. So what Genentech did was they created one molecule, not two. And they looked at superiority in the Avenue trial. They couldn't demonstrate, so they pivoted and they went for durability. And the durability, they looked at Tenaya and Lucerne and found that the drug works well. It gives visual acuity results comparable to aflibercept, and it seemed to have a durability effect. What we don't know is what the contribution of Ang2, because these molecules are created with several differences. So is it the Ang2 that makes a difference? Is it the fact that it's a larger molecule and has a longer half-life? Or is it the fact that it's a higher molar dose? And the answer is we don't know, because all three are part of the drug and we don't know which it is. When you look at what the FDA says, the FDA said that the contribution of Ang2 inhibition has yet to be established. So that was after approval of the drug. They approved the drug based on not its Ang2 binding, but based on its overall performance. But even the FDA said, we don't know if Ang2 binding makes a difference. And back in 2023, I was at a meeting in San Francisco, and I talked at one of the breaks to one of the. He looked at me and he smiled and he said, "We still don't know if Ang2 binding makes a difference." And that came straight out of Genentech after faricimab was approved. So what is interesting is that Ang2 levels generally correlate with VEGF levels. And what these scientists at Regeneron established was that as VEGF levels go up, it stimulates Ang2 production as sort of a magnification effect on endothelial cells. And so even the people at Regeneron had written that Ang2 plays an important role in angiogenesis. We don't know that it's an independent role because the people at Regeneron, led by their chief medical officer, George Ankopoulos, couldn't establish that it was a separate entity, but rather it was intertwined very significantly with VEGF. As VEGF levels rise, Ang2 levels rise. As VEGF level falls, Ang2 levels fall. Do we have any good experimental data to show that? Well, we looked at the Avenue trial and we saw that generally over the course of 4 weeks in almost every treatment arm, the Ang2 levels fell as patients were treated with any number of different regimens, being ranibizumab as a monotherapy or combination therapies with faricimab. But what I found really interesting was this graph. And this graph is from the Avenue trial. And it looks at baseline concentrations of Ang2 in gray, and then the concentrations at week 4, 1 month after the initial drug injection. Faricimab, the Ang2 levels fell dramatically from baseline. But look here, this is ranibizumab. And ranibizumab is only anti-VEGF. It's not Ang2, but the Ang2 level fell to almost 0. Why? Because the VEGF level fell. VEGF is a major stimulator of Ang2, so the Ang2 levels fell as well. So for that reason, we're really unclear that targeting Ang2 makes a difference. Ang2 contributes to angiogenesis. Ang2 is largely dependent on VEGF concentrations. So biologics, I'm sort of preaching to the experts on this. You people in India have had much more experience than probably anybody else in the world with biologics since you got molecule Generics are 300 to 400 Daltons. Here we're talking about molecules that are well over 100 times that size with long chain amino acids, and are put together in both primary, secondary, tertiary, and quaternary structures. And so very difficult to replicate by a company wanting to produce a biosimilar. And that's why they're called biosimilar, but they're not called generics because they're not exactly the same. In part, it's because you can't replicate the entire molecule unless you absolutely have the map at baseline. And part of that is excipients, and part of that is glycosylation. And so you have these glycosylation sites on the molecule that are important in terms of safety, immunogenicity, durability, et cetera. And those are things that are hard to replicate. And that's why we shouldn't necessarily assume all biosimilars are exactly the same as its originators, because you have different excipients in the solution and you have different areas of glycosylation that can't be replicated by the producer of the biosimilars. That's why pharmacovigilance after the fact is so important. And I know I'm preaching to the choir here because you had some early inflammatory problems with Razumab, and I believe you've had some early issues with the aflibercept biosimilar as well. And so it takes a while sometimes to get past the manufacturing processes that are very critical to getting these drugs to the point where they're safe. And then the other thing that comes into this is that when we look at the phase 3 trials for the standard anti-VEGF drugs, we're looking at over 1,000 patients. When we're looking at the phase 3 trial for the biosimilars, we're looking at about 200. And so even though none of those trials is powered to show safety effects, you get a lot more reliability in over 1,000 patients than you do at 200. And so wait and see may sometimes be necessary. It depends on whether you're an early adapter or whether you're a wait and see kind of person. It's very reasonable to see what happens over the first year or so with the biosimilars. I tend to be slower with the biosimilars because I do worry a little bit about pharmacovigilance problems that take a while to surface. We learned that about brolucizumab. But here's even a drug that went through standard phase 3, but it was only post-approval that we had enough biovigilance to see that the inflammatory problems in the US or in the populations in phase 3 actually turned out to be a pretty significant problem as we interpret them in the United States. Can we make the drugs better? Can we make drugs that are either better efficacy or longer durability? And there are several different strategies that can be used. One strategy is to create a drug that has a very strong binding affinity so that it's biologically active at a lower concentration. So it grabs VEGF even when the concentrations are lower, hence turning off the VEGF drive. And that's a great strategy to use. We may not have the ability to make it better. And the reason for that is aflibercept, because of its three-dimensional structure, is the strongest binding molecule to VEGF of any clinical or experimental molecule that's ever been proved. So we may not get much better. So there are other avenues to explore, and one is increasing the molar dose. And of course, this is the strategy that's been used by brolucizumab. It's been used by faricimab, which is more than 2 times the molar dose of aflibercept. And of course, this is the strategy that is being used by Regeneron Bayer in terms of developing 8 milligrams. And when you look at a cartoon, it's fairly simple to think that you have more molecules at baseline, and over time, the concentrations fall in a first order mathematical process. But at any time point down the road, you have more molecules left in the eye, hence longer duration of time where your concentration of drug is above the inhibitory threshold. And so, can we do that in terms, how is that going to affect our patients? Well, we don't think of aflibercept 8 milligrams as an efficacy molecule, even though we do see signs of that with drying, and we see signs of that with early disease control. But what we're looking to do is to try to increase the duration of action on all patients, not just get patients to 24 or 20 weeks, but to get those patients who are at 4 and 6 weeks. And can we decrease the number of patients who are require frequent injections and move them out a little bit so they come back less frequently? As well, we look at the patients who are doing fairly well, and see if we can extend them even further or get them to the point where maybe we can more safely stop the medication. My rule of thumb with aflibercept 8 milligrams compared to 2 milligrams is if a patient is doing well on 2 milligrams, I've got an interval where it's defined that they do well. I can increase that by about 50% with 8 milligrams. I can go from 6 to 9. I can go from 8 to 12. That's my rule of thumb when I'm seeing these patients. And so 8 milligrams is looking at sustained disease control for longer periods of time. And what we see in clinical trials and we see in practice is you get much faster control of disease, which gives you the confidence that your disease is under control, and hence what you can do is you can go ahead and then extend them much quicker. And so final slides, looking at global trends. This is from the PAT survey from ASRS 2025. Most physicians, either international or US, if looking at AMD, no payer restrictions, aflibercept 2 milligrams remains the drug of choice. And certainly for diabetic macular edema and worse vision in 2040, the Protocol T guidelines, aflibercept again remains the drug of choice for most of these patients. So aflibercept has been the global leader, 2 milligrams. And even with 8 milligrams, it's a very good drug, and we'll obviously talk about that as we move towards the use of the drug. But aflibercept is a difficult drug to overcome because it has good efficacy, it has attractive durability, and it has an unmatched safety profile amongst any of our anti-VEGF drugs. So thank you very much. Turn on his microphone, please.
Okay, thank you, Dr. Stewart, for that very comprehensive discussion taking us through fluid and then switching and then molar concentrations and then the biosimilars. So I would like to initiate this discussion with raising a point about the different molecules that we have today. So what I gathered from your talk, what we are seeing now as the second gen anti-VEGFs which are coming in are somewhere more playing towards a longer duration, more based on their molar concentration than a pathway difference. So even with faricimab, we see a higher molar concentration with brolucizumab, as you said, and then 8mg also. So does that pathway actually doesn't carry much of a value, or is it just the VEGF molar concentration eventually, which you feel is what is pushing all these molecules further?
Yes, so I agree with the way you finished that and saying, I think it's the anti-VEGF concentration of the drug combined with its binding affinity and then its duration in the eye that is determining the durability or the extended durability of action. So when we look at the drugs that we have and we compare them, brolucizumab is a really good binding drug because it has very high concentration, but it has a very short half-life. And so of all of the drugs that we look at, I think brolucizumab is probably the one with the poorest durability signal. And not because you don't put enough molecules in the eye, but because they leave very quickly, because it's a very small molecule. And so it dries fast because that's a high intraretinal concentration. It doesn't last long because it has a short half-life. And so you have to find a balance between size of the molecule, binding durability, binding affinity, and molar concentration so that you get that durability effect. One of the reasons why aflibercept does so well in terms of durability is its very high binding affinity, because it can work at a lower concentration compared to the other molecules, because it has an order of magnitude or more higher binding affinity than the other drugs do. And so it lasts fairly long in the eye because it's a bigger molecule and has a longer half-life. And by quadrupling the dose, we're going to get an extended durability on that. But you're right, all of the second generation drugs have been developed. Everybody thought they might get a signal for efficacy. Everybody was wrong. It's all about durability, and that's the direction we're going.
So just going in extension, when we talk about with this, the switching, normally when I saw you typically are working on a particular molecule and then you move to another and then you continue with 3 or 4 monthly intervals of that molecule before you decide whether it is working or not working. But now looking at 8mg coming in,
yes,
It's essentially the same molecular higher concentration.
Yes.
Do you still need to load up these eyes, or you can straight away switch and start hoping for a extension from point one itself?
So really good question of do you need loading doses after switching? And I would qualify that by saying, what is the state of the eye in the pre-switching treatment regimen? So all the patients that I showed you were eyes essentially that were not responding completely well to previous therapy. So we're getting 4 to 6 weeks and they're not responding well. So you're going to want to treat them every 4 weeks, and you're probably going to want to treat them until stable. In diabetic eyes, of course, stability doesn't happen quickly. Stability takes time. So many of these require monthly injections. Now, if I have a diabetic eye that is doing very well on Q8 weeks, but I can't get them beyond 8 weeks, then I'll switch, but I'll start off at a single injection at 8 weeks, and then I'll go beyond that. So I won't load on an eye that is already doing well and is switching for durability. I will load on an eye that has an incomplete response. Those are the ones that need the rapid improvement in disease control.
Thank you, Dr. Stewart. Very nicely put that. Dr. Ajay.
Yeah, I have means you have gone through a lot of subtopics of the same talk.
Yes.
So we may have to go with the subtopics. Okay. You said the fluid at intraretinal and subretinal level, but somehow you have not dealt so much about the sub-RP level. In these cases, what I see with multiple injections, there is a RP with multiple injections. How would you take it, and how will you go forward with that?
Yeah, so why do we get the scarring? Many of those eyes are ones that where you get a improvement in your RPE detachment, but you don't get it completely collapsing. And I think those are the ones that you're talking about. And then you get the increased echogenicity coming out of the sub-RPE space. And the scarring is probably an inactivation of the most of those are type 1. And most of those are probably an inactivation of the membrane. And so you're creating a neovascular complex and turning it into a fibrotic complex. Is it optimal? But it's something that we have very little control over, do we? We're not treating to try to get rid of the pigment detachment. We're treating to try to improve the vision and manage fluid compartments within the retina. What happens in the sub-RPE space is sort of secondary. One of the things that worries me sometimes is a collapse of a pigment epithelial detachment is often followed by significant atrophy down the road. And it may be that some of the fibrosis in the sub-RPE space is actually protective over the long run in terms of viability of visual acuity. So I don't know that it's necessarily a bad thing, but I think it's a consequence of inactivation of the neovascular complex.
While assessing the fluid components between these three compartments, will you still consider that sub-RPE fluid is important or not?
If it's associated with intra and subretinal fluid, then it is. And those are ones that probably resolution of the RPE detachment achieves better visual acuity when accompanied by the other two. And then size or enlarging RPE detachments do matter. And those are the ones I want to treat aggressively. So those are the two ways I think about that. But if I start off with a mild to moderate sized RPE detachment in the presence of subretinal or intraretinal fluid, and all of my other fluid goes away, or at least the intraretinal fluid goes away and the sub-RPE fluid, subretinal fluid improves, I'm happy with the pigment detachment in those eyes. If we adjust for your refractive error, because these patients become relatively hyperopic, then they generally do pretty well. And I won't chase the RPE detachment in those cases.
Dr. Stewart, if just offshot thinking here, the aflibercept has a strong VEGF action and a anti-PGF action.
Yes.
PGF associated with fibrosis.
Yes.
Have you seen any difference in using 8 milligrams with a higher concentrations, working on higher PGF levels to work on the fibrosis that you were talking about?
I've not. I know it resolves fluid better and quicker, but in terms of fibrosis, I've not seen that. And post hoc analysis.
What you mentioned that Map.
I more with the second generation agents. I'm starting as a first line therapy. And if we're speaking of macular degeneration, which is most of the talk was, then remember in the Pulsar trial.
That's right.
And so in real life, how do we use new drugs? Well, let me see a patient who doesn't respond very well and I'll switch and I'll see what happens. Well, if we look at switching results, that's not where you get the wow effect. And that's not really how the patients were studied. And it's not where you see the drugs working at their best. And so really, if you're as a first line therapy is the way that makes the most sense because that replicates what we found in the approval trials.
G versus 2. So regarding coming to the drying effect, so does the 8 mg has the same level, lesser drying effect as compared to the faricimab and the brolucizumab? And we are increasing the concentration.
And I speak with admiration for my colleagues from Bayer. There will never be any trials that will look and compare them side by side because Bayer won't be interested. Genentech's not going to be interested. Nobody will actually do that. So we'll look at real life trials or trials from institutions. So the short answer is we don't have any good drying effect to see that. And so what we can do though is we certainly can compare 8 milligrams to 2 milligrams. And 8 milligrams dries faster and dries more completely. Now, over time in AMD, and we see this with all the trials, is an improvement in drying effect. What's very is at the end of 2 years, patients receiving 2 milligrams were switched to 8 milligrams. And what they found was the drying effect after one injection was significant, much better than any of the drying effect at the previous 2 milligram doses, and it lasted longer. So what that tells us is even after that there still was fluid left that could be resolved with 8 milligram. Does that improve the visual acuity going forward? The data says probably not. You're probably already at your maxed visual acuity, but what it does do is we see it controls the disease to the point where we can extend patients longer, hence the durability signal.
And second question between 2 mg and 8 mg. Let's talk about beyond visual acuity improvement and the CRT reduction.
Yes.
What about your personal experience in contrast improvement?
Oh, in contrast improvement, patients are happy with the 8. If you're talking about contrast sensitivity, I've not measured them. So I don't know the answer. And I don't think that was part of the trials. They looked at visual functions, but they didn't do contrast sensitivity. So don't know. My guess is at least as well, if not better, because of more rapid fluid resolution. That's the best I can tell you.
Thank you.
Yeah, there's a question from the audience.
So historically, AMD, age-related, people thought because of age in systemically, like osteoarthritis, biosimilars, those who are taking anti-edematous medicines like diacerin, Flexide D, chymotrypsin, like that, incidence of wet AMD or dose of aflibercept, any reduced?
I'm sorry, say that again. I missed your question. I'm sorry.
Concept of biosimilar.
Yes.
Chymotrypsin.
Yes.
And diacerin, those they are taking for osteoarthritis patients.
Okay. Yep.
Whether they have an impact in the incidence of wet AMD or the dose of these medicines.
Yeah, I'm not aware that it does. That's the best I can tell you.
That's best.
Doctor,
Yes, and I don't know the answer. I'm sorry.
Dr.
And, VEGF and ANS2 how do you define what is the percentage of Ang2 effect and VEGF effect?
I don't think you can. Related to each other, and they do move in conjunction with each other. And does incremental attempts to bind Ang2 make a difference? Genentech or Regeneron didn't find that it did, and Genentech found a good molecule in faricimab, but we have no idea if it makes that the anti-VEGF arm works well. But we don't know that the Ang2 contributes. We just don't know.
Those Novartis did not claim ranibizumab is showing some effect on Ang2.
I know. They don't want to claim that. Yes, exactly. And that goes back to what the scientists told me. It goes back to what the FDA said. The FDA said, as they approve the drug, we don't know that Ang2 binding does anything.
You have not claimed.
So just to assuming that you would use faricimab only as a switching drug and never as a.
Yeah, so I've inherited patients from a couple of people in my practice that have resigned and retired. And so many of them were on faricimab, and I keep them on faricimab when they're working well. They do well. I generally don't use that early on in my own pathway. And more now, I'm treating patients with 8 milligram as a starting agent. Sometimes it's based upon insurance and their coverage. We do have incidences where some patients who don't have Medicare, which is for government insurance for 65 and over, but are just under the age of 65 who have choroidal neovascularization, who are required to start on bevacizumab. And so for patients under 65, if they come in with choroidal neovascularization as either from macular degeneration early onset or another neovascular disease, I will give them bevacizumab in the office today, bring them back in 2 or 3 weeks, and get pre-approval for 8 milligrams, because I don't want them getting stuck with the bill. But I try to move to 8 milligrams as quickly as I can in those patients. But insurance does play a role in who gets what.
Yeah, Bayer was saying that we have to wait for 4 or 5 months before we get the items. So can you give us some indications that how do you use 8 mg versus 2 mg in your clinic?
Yeah, I have a couple of cases for the 8 mg. So let me show you. We'll start with this one. You've seen this.
Yes.
This is the patient that I showed you,
Yeah.
where the patient was switched to faricimab and got worse. Actually, I had 8 mg available at that time, and I switched to 8 mg, and you can see single injection to 20/40, improved swelling, and we're down at the bottom. And here we are out at 7 weeks, and the patient's doing well, not perfectly, but well, and certainly as well as the patient had in the last 3 years. And that's at 7-week intervals, not 4 to 5, which is what mostly the patient had been doing. So the patient's actually done well and continues to go along at 20/40, of course, reading and driving vision, and we're out at 7 weeks. Here's a patient, 82-year-old patient who was treated on 2 milligrams for a long time. This is subretinal fluid. And, I thought maybe 8 milligram will get rid of the fluid. Now, that kind of flies away from many of the things I said of tolerating subretinal fluid. But the visual acuity was 63 letters, and I thought maybe there's more letters to be gained. So now I'm switching. So I'm going against many of the things I said, but sometimes you try things and you try to figure it out. So I switched the patient to 8 milligrams, and you can see the visual acuity is improving, 67. The fluid is probably dry, and a little bit of fluctuation as we go forward in 68 letters. So sometimes we get fairly lucky, and you get the new drug that comes in and dries the patients where the old drug doesn't, and you'll get a couple of letters of vision. Of course, what do you do if it doesn't work? Be ready to switch back, always. So there are some patients where you will get that happening. Here's a patient, 76-year-old, decreased vision metamorphopsia in the left eye, not surprisingly, fluid in all compartments. And so started the patient on 8 milligrams. Patient comes back and it's pretty dry, 20/60. For one reason or another, 7 weeks was the next one. Now, what I normally do? I don't believe in 3 loading doses are required, but I believe in loading until disease control. But in this case, the patient did come back at 7 weeks, but even look at the difference between the 7 weeks versus 4 weeks. And even with that extension, the patient has continued drying. the visual acuity is getting worse. What does that mean? It means that the technician and my technician doing the vision and the patient didn't like each other that day. And so if the morphology is looking better in the short term, I don't worry about individual fluctuations in vision. Because as we go forward, we get this. Now we're at 2030, patient's looking good, we're at 11 weeks, and then we go out to towards 15 weeks. So that's a patient with neovascular AMD, new onset, treated with 8 milligrams from the start, without loading doses. One injection, 4 weeks, and then to 7 weeks. And here is another patient with, you can see significant subretinal fluid. You can see here, there's fluid in the macula, of course, the submacular hemorrhage. And here is the OCTA. And when you look, it's very interesting. There's a leach of blood vessels coming from the peripapillary area and a nest of blood vessels here. So it's all extrafoveal neovascularization. So we think this eye should do really well because you don't have subfoveal neovascularization. So 8 milligrams, patient comes back in 4 weeks, and you can see that the subretinal fluid is almost completely gone. You still have some thickening right up there, right where that nest of blood vessels is. The retina's thickened. So we go again 5 weeks, now to 7 weeks. And by 7, you can see that that little bit of residual thickening is completely gone in that area. And so now we go out 9 and then towards 11 weeks, and the patient does very well. Again, fairly rapid onset of disease control. Better with 8 milligrams than we see with 2 milligrams. This is a very short one. 73-year-old physician with new onset left eye, previously treated with monthly anti-VEGF. He said he never really got dry or never really got asymptomatic. And here how he was at baseline. And you can see why with the shrim and the subretinal fluid. So I gave him 8 milligrams once, and he comes back after a single injection, looks like this, whereas he'd never been dry on other agents prior to that. And then we continue along, and he's never had vision this good with previous treatment. And the vision doesn't diminish as he approaches his next treatment interval. So again, speaking to the rapid onset and the durability of disease control.
Dr. Stewart, just notice something that your extensions are typically 2 weekly extensions.
Yes.
They're not doing
Yes.
any 4 weekly
Yes,
extensions.
I'm a coward. So I'd rather say I'm conservative. Now, I do have some patients where, and I haven't brought those slides with me, but as I get the further and further along, I extend by more and more. So I may start by 2-week extensions, but I get out at 9 weeks, and then I go to 3-week extensions. Then I get to 12 weeks, and I go to 4-week extensions. So I'm sort of reassuring myself that these patients are extendable. I think that based on experience that we have, 4-week extensions starting after whatever loading doses you have is very reasonable. I'm not a big fan of going what was done in the trial, which was 3 monthly doses and then 12 weeks or 16 weeks. It worked for the trial. I'm not that brave. And what I would personally do is go from that maybe to 8 weeks, and maybe to 12 weeks, and maybe to 16 weeks. But I hate the idea of missing that interval of Q4 to Q12.
Do you patient monthly or?
No, no, we think that treat and extend means we've already tested the previous interval that works. So I'm assuming that they're okay. And then I do tell them though, if it gets worse, call me. I do tell them that. My patients usually are not very shy, and they tend to call me if need be.
Any questions from the audience, please? Right.
Okay.
Thank you, Dr.
Thank you very
Stewart,
much.
for that engaging discussion.
Very good. Thank you.
Wonderful talk. And this we will move to our next speaker. Invite Dr. Shriram to please talk to us about DME, specifically visual outcomes in DME and efficacy with Q16 FUSL.
Full screen.